Good evening. Welcome back to the Ask Me Anything. I'm Dr. Twyman, board certified cardiologist, helping people not have heart attacks and strokes. That's my mission at Apollo Cardiology in St. Louis, where we take care of patients from all over the country and the world, Australia, Canada, to name a few things. So every Monday, we at 6 p.m. We do questions that have been pre-submitted early in the day, and if we have time, we answer the questions in the comments. My job is to educate, maybe entertain, but mostly to educate, I think. That's what I really enjoy doing. I used to take care of people in the cath lab, help them, when they're, at their most vulnerable. It's very rewarding to help people having a heart attack, but I always thought it'd be a little bit more useful if I took my skills and help people prevent having the heart attack. So that's what I've been doing now. Practice has been open since 2019. So we'll be talking about the questions in just a moment. Just a little bit of housekeeping. We had a great retreat the other week at the Canyon Ranch. Did a lot of hiking in anticipation for my climb to Kilimanjaro next year. Still doing a lot of climbing here in St. Louis. So that keeps me busy outside of this practice that I do of cardiology. But if you're ever interested in more education, what I can do on Instagram, I do have a Skool community. I just dropped a video there. All my thoughts on the newest hypertensive guidelines, best ways to treat it with a lifestyle intervention first, what supplements tend to work, what screening devices I use, considering blood pressure monitors that are wrist bound, but which ones actually work, like the Hilo, brachial cuffs, why you'd want to use one, and then talking about nitric oxide availability, and you can use test strips to figure out if you have good nitric oxide through your salivary pathways. Also, we'll be doing monthly Q&As there where it's a little bit more in depth. It's live with people going back and forth. They can share more information. So if you're interested in Skool, it's drtwyman.com/Skool. Excuse me. Or it's skool.com/drtwyman. It's also in my Instagram bio if you ever need a link to the Skool community. The other housekeeping thing is that I did a demo last week with the Echo company. This is one of my fancy stethoscopes I use in the office. Does an EKG as well. But they recently upgraded some software where it used to be available only for big academic centers. Now it's available for private practices. But you can use this device to assess if somebody's heart is weakened. Do they have a cardiomyopathy in medical speak? Do they have an abnormal heart rhythm, such as atrial fibrillation? Do they have a cardiac murmur, such as aortic stenosis or mitral regurgitation? So looking forward to upgrading the software and then having this be kind of the state-of-the-art screening that we're adding to our practice at Apollo Cardiology. Still in the process of trying to upgrade our systems to be able to do AI EKG, which would tell us how old you are, and also essentially going to give us information in the future about how healthy your liver is, what is your risk of having coronary artery disease. A lot of new features coming down the road through AI. So with the housekeeping out of the way, we'll jump into the main questions tonight. ApoB is 102. Is this concerning? How to naturally lower? So ApoB is just a marker of risk. ApoB is not a disease. The concern is if you have atherosclerosis. If you have plaque in your arteries, then ApoB of 102 is above the 50th percentile. You generally want to be less than the 20th percentile, so an ApoB of 70 is the goal. Naturally lowering it, well, depends. Do you have an ApoE4 issue? Do you have a lipoprotein lipase enzyme deficiency? Are you insulin resistant? Are you keto, carnivore? Are you vegan? It does depend a little bit nutritionally, but most time ApoB is genetically predetermined. And if you're a hyperabsorber, potentially things like bergamot may help. If you're a hyperabsorber, generally fiber is really the only lifestyle thing that has an effect for it. What are my feelings on infrared sauna? Excellent. I have one at home. Any tips on buying a home sauna? Look for one that is, hopefully listed as low EMF. If it's not, then you got to take the advice of influencers, unfortunately. But if you buy an EMF meter, you can test it yourself. That's what I did when I got a sunlight sauna. They reported to be low EMF, but if you laid right up against the panels, it was generally very high. So I just sat on the bench and never put my back all the way on the heating elements themselves, and it was relatively straightforward. But currently using more of a pop-up tent, the relax sauna, one-person sauna. Nice thing about it is that when it's summertime and it's hot in St. Louis, you can break it down and put it away. It doesn't take up any space. Do I recommend contrast therapy? I know what it is. So alternating between hot and cold. So when I was in Finland a couple years ago, I definitely did that. You stayed in a sauna, got super hot, went out and rolled around in the snow to cool down, or jumped in the Arctic Ocean, then went back into the sauna. So if you're doing contrast therapy, it's always best to end on cold and naturally rewarm yourself. Person walks at sunrise, but they're up an hour earlier. Should I wear blue blocking red glasses until sunrise? I would say it depends. I mean, I personally just wear my yellow lenses that I'm wearing right now. My house has different lightings. In the morning time, I have this under cabinet red light so I can make my coffee without stumbling in the dark. The red lenses tend to make me very groggy, so I only generally wear them in the evening time. But if you're not that sensitized by them, then it's okay to wear the red ones in the morning before the sun rises. If you have trouble taking a statin and cholesterol is very high, what should you do? Again, cholesterol is not a disease. You're looking for atherosclerosis first. That determines how aggressive to be with modulating your lipoproteins. But work with somebody who knows how to manage lipoproteins. Statins are just one tool, but not everybody can tolerate them. In the studies, probably 8 to 9% may not tolerate any dose of statins due to muscle side effects. But if the person can tolerate a statin, ezetimibe, a PCSK9 inhibitor such as Repatha, or the newest medication, bempedoic acid, that has MACE data, major adverse cardiovascular endpoint data. So if you're going to take something, you want to make sure that it actually lowers some type of event that you care about. Less heart attacks, less strokes, need for stents, dying. Just making a number look pretty on a lab isn't the key. It's having less cardiac events is the key. How much does stress, chronic and acute, play in cardiac events? Significant. Don't have an exact percentage, but probably definitely more than half. So there's some reports that probably 80-90% of office visits to a doctor are related to the side effects of acute or chronic stress. There are many ways to kind of modulate stress, but how to test for it, it's a little bit challenging at times. You can look at salivary cortisol levels. You're doing an adrenal stress index type of test. You can look at heart rate variability. That's what I tend to use, for patients because I'm a cardiologist and people have wearables that are monitoring that. So the rings, the bands, chest straps all measure heart rate variability, which is a metric of your sympathetic nervous system balance. So if you're not modulating your stress well, that definitely can age your arteries faster. The catecholamines can constrict the arteries. The catecholamines can damage the glycocalyx. So for those patients, I recommend that they find a restorative way to manage their stress, not alcohol, not things that are going to put more stress on their body longer term. So things like meditation, deep breathing exercise, biofeedback, heart math, which is a biofeedback type of device, the Respirate device, it's a breath trainer. Grounding helps with balancing the nervous system. So stress isn't the problem. It's helping modulate it is really the trick. Somebody says a meta-analysis showed a cardiovascular event risk reduction of only 1.3% with statins. What are my thoughts? Depends on what the meta-analysis was looking at, but based off of the reduction, you're probably talking about somebody who's taking a statin for primary prevention. So that is on par with what the data shows. Statins are tools. Use the right tool for the job. Statins' main benefit is for secondary prevention. You've already had your chest cracked open for a bypass. You have stents. You've had a heart attack. You had a stroke. Statins have a more significant absolute risk reduction in those individuals. But primary prevention is somewhat of a misnomer because what testing are they doing to confirm that you're primary prevention? If somebody did a Cleerly CT angio with me, I would be highly suspicious that they're truly primary prevention. They're probably more like primary 0.5 prevention. Because if you look for plaque in most people, you will find it. Are they still primary prevention at that point? Not as much. Primary prevention means you've never had an event and you don't have plaque in your arteries. If you look for plaque with a very sensitive test, you're in a high risk category. And if you're 80 years old, that's probably not a big issue if you don't have significant plaque. But if you're 40 years old and you hope to live to 80, 90 years old, even if you only get a 1.5% reduction over the 5 years or the 10 years maybe that the studies were looking at, you don't know what is your 40-year risk reduction. So you individualize it to the person who's in front of you and what's going on with their arteries. Somebody says that their calcium score is 70. They say they know it's bad, but how do you get it lower? Calcium in the walls of the artery is a marker of plaque. The higher the score, the higher the risk. 400 is considered high risk. Generally about a 15% risk of having a heart attack over the next 10 years if you don't do something about it. Calcium scores over 1,000 are very high risk. Approximately a 1/3 or 33% reduction or 33% risk of having a stroke or heart attack if you don't do something about it. So how do you get it lower? Well, you don't necessarily want the calcium score to go down. You want the plaque to stabilize. The softer plaque to either delipidate and shrink, or you want the soft plaque to become hard plaque. And oftentimes the calcium score test will go up. If you add a statin to your regimen when you have a calcium score of 70 and you weren't on one before, oftentimes the calcium score test goes up. That's not necessarily a bad thing. You're taking soft plaque that can cause a heart attack and you're firming it up. So test, don't guess. Figure out, do you have low nitric oxide or dysfunctional endothelium? Do you have a lot of oxidative stress or inflammation where your arteries are on fire? Do you have a significant dyslipidemia? Do you need to consider, changing up your lipid-lowering therapies? Those are the starting points, but there's up to 400 things that damage your arteries that can cause the arteries to calcify. So work with somebody who can do that type of testing and figure out what is driving it and then pull on those levers. Which is better for your mitochondria, cold plunge or red light therapy? I don't know, this is a trick question. They're both good. If you only had access to one, I probably would lean more towards red light therapy because you're more likely to consistently do it. But photobiomodulation, increases the spin rate of the ATPase. The cold plunging helps speed up the electron flow through the mitochondria electron transport chain. Both can be beneficial. Do bioidentical hormones help your heart or cause heart attacks? I started after age 60. This does not tell me if this is a man or woman, but typically, hormone therapy done correctly, where you're in physiologic ranges, generally will not increase risk. But will they decrease cardiac events? That data is more murky. Probably not. But if you're very low on certain hormones, so in general, if you're low in estrogen for a woman or man, it's going to affect your vasodilation in your arteries because estrogen has an effect on nitric oxide. Estrogen is important for brain function. So if you're cognitive, having issues, low estrogen may be in effect. It's important for libido. It's important for bone mineral density. Progesterone in women, very helpful for potentially keeping them asleep, helpful for joints. And then testosterone, helpful for muscle mass and libido. So typically, if you're working with somebody who knows what they're doing, keeps you in physiological ranges, not at increased risk of heart attack. If you want to know more about this type of topic, I'll be speaking at the Silverback Summit later this week with my friend Ali Gilbert. It's probably the premier men's health conference in the United States where people get together and discuss these type of topics. And I'm talking all about heart disease and hormone replacement therapy in men. Somebody says they're asking for their father. Any good ways to recover from a stroke? So hard to hear about that. It does depend on what territory of the brain was affected. And also, in part, depends on what is the etiology of the stroke. Was it thrombotic, where there's a blood clot? Was it ischemic, where there's lack of blood flow? Was it hemorrhagic, where a blood vessel actually burst? So that will determine a little bit on the recovery part of it. But, without knowing more details, then blood pressure controlled, depending on what the neurologist is comfortable with, but ultimately probably getting closer back down to 120/80 at some point. aggressive lipid-lowering therapy, I probably would, look at an ApoB target of 55 in this type of individual. You would want to make sure they're metabolically very flexible and that they're not having evidence of insulin resistance. Getting optimal levels of DHA through seafood ingestion. And so your brain has approximately 30% DHA. You need the DHA to capture essentially sunlight energy to pass it on to the neighboring cells. And then working, depending on what the deficits are, working with a good occupational therapist and potentially physical therapist. Somebody says mild plaque shown in a carotid scan. Calcium score clearly prior to HRT for 63-year-old. The Cleerly scan is a more sensitive test because it will also look at how much soft plaque is in the walls of the artery. It can also give you more data about if you have any stenosis or quote blockages in your arteries. I don't necessarily use either just as a go, no-go type of decision for somebody starting hormone therapy. I would just use it as that atherosclerosis is the number one thing that kills people. So I want to find plaque as soon as possible and start treating it. All right. So those are the pre-submitted questions. Excellent as always. The replay will be in my feed in short order, and then these videos ultimately get uploaded to my YouTube channel, drtwyman.tv. And there's usually an AI summary under there, so you can go back and look at some of the archives in the past few months and find the answer to your questions. Is there a blood test to show if you're a hyperabsorber? Yes, the cholesterol balance test is what shows that. That's available with Boston Heart Diagnostics, and I use that test in almost all my patients. If you're a hyperabsorber of cholesterol, which may happen in up to 20% of the population, and if your lipids are not controlled with other measures, then ezetimibe is usually the best option for those individuals. Seeing some familiar faces, some patients on here, so welcome, guys. Was cardiovascular disease less common 100 years ago? No, you just died more frequently from it. Now it's actually treatable. But infectious disease and trauma were still more likely to kill people at that point. But there's mummies with coronary calcifications that they've done studies on before. So cardiovascular disease has always been with us, but oftentimes people didn't live long enough to develop severe atherosclerosis. Thoughts on a saturated fat with a calcium score of 212 and elevated LPA. Doctor says only eat plant-based. So you may need to ultimately look for a new doctor because plant-based can work for some people if they choose that, but is not the only answer. Saturated fat doesn't always affect people's lipoproteins, typically more when patients are ApoE4 carriers. If they have certain genes that affect lipoprotein lipase, it may. If you use the Boston Heart Diagnostic Panel, you can see how well they're absorbing any type of saturated fat that they're eating. So then the person's got to make the decision. Do they want to make a big nutrition strategy change to try to affect the lipoproteins? Or since they already demonstrated they have a more than intermediate risk to have a calcium score test, then maybe they should just start being more aggressive with whatever lipid-lowering therapy they're willing to consider and try to shoot for an ApoB under 70. But that's a question I get often from many patients that come work with me. Does my circadian UVA window end about an hour before the actual sunset in this fall season? It completely depends on what is your latitude from the horizon of the equator. So the further north you are, the shorter the UVA window will be. In more warm type of environments, typically when you get up, sunrise is not that warm. When your skin starts to feel warm, that's when the UVA wavelengths are getting through the atmosphere. But it's when the sun is at 10 degrees or greater in the atmosphere is when UVA gets through. So it depends, but generally it's between 30 and 60 minutes from sunrise. And then it reverses near sunset. It looks like that was the last of the questions tonight, guys. That was great. Every Monday, 6 p.m. Central Time, we answer the questions, try to help you become heart attack proof. If you're looking for more education than what's allowed on Instagram, my Skool community, drtwyman.com/school or school.com/Dr. Twyman. Both addresses take you there. The members in there are pretty good about helping each other, but I'm doing weekly polls, whatever the best upvoted topic is. I'm going to put a video in there. I just put a video in there tonight about different blood pressure screening devices, goals of blood pressure treatments, lifestyle-wise, how to work with your doctors on lowering blood pressure. And then if you end up on pharmaceuticals, how to consider which pharmaceuticals might work better for you. If the topic is going to be lipids, then I'll talk about lipids the following week. We do, 1 hour AMAs at least monthly in the group, and then going to start doing a little bit more kind of share behind the scenes of what we do at Apollo Cardiology, what testing we do, what testing I recommend people do at home. So if you're interested in that, check out the Skool community. There's a free 7-day trial. If you like it, sign up and hang along with us. Keep working on becoming heart attack proof. So hope you guys have a great week. See you next Monday.